You're live.
I can start.
Yes.
Okay. Good evening, all. My name is Ila Elina Dhiambo, a clinical nutritionist. I'm going to take us through the management of severe acute malnutrition in patient. Um, the objective of this talk is actually to define malnutrition, to identify the clinical signs of malnutrition, the anthropometric indicators, the admission criteria, reductive adaptation, and the 10 steps to the management of malnutrition in patients. Okay, malnutrition generally describes poor food intake causing an imbalance in the nutrients in the body. It could be in excess or inadequate. So that's you have overnutrition or undernutrition. Undernutrition is when there is lack or inadequate dietary intake, which could be due to diseases or it could be due to pre-existing conditions. It could be due to poor intake and a short-term malnutrition, as we know, is uh, leads to chronic malnutrition leads to stunting. That is a child becomes short for their age, and short term leads to wasting. You see a baby and they don't have muscle in their body, they don't have enough fats. And it could also mean deficiencies in things like vitamin A, iron, and zinc. Overnutrition occurs when there's excess intake of nutrients. Hence, the body stores the excess in form of fat and is also a risk to health. The clinical signs of undernutrition, the things that we can see with our eyes, includes seeing a child who's severely wasted, has lost fat and muscles, and this one can also be referred to as marasmus. If you look at a child, they look severely wasted. If you remove the child's clothes, you're able to see the ribs, and you're able to see skin on the upper arms look loose, like around here. The skins can be hanging, and also the same could be in the thighs. And then the child is likely to have baggy pants, and the ribs are you can see the ribs very easily. The other indicator of malnutrition is edema. Edema, though, sometimes can be confused. Like if a child has nephrotic syndrome, they're likely to also present with edema. And the only way to confirm is like conducting a urine test for every child presenting with bilateral pitting edema. Edema is accumulation of fluids in the tissue. Most of the time, the fluids accumulate in the tissues. And if you were to hold the child's feet, for example, and you press for like 3 seconds, it will leave a dentation in the feet. So the degree depends on how far the water has accumulated in the body, because we start from the legs. That is, both legs are swollen. It will be mild edema. Moderate edema, you'll have edema in both feet, lower legs, and the lower arms. And in severe cases of edema, you're going to have generalized edema in the whole body. You'll have edema in the legs, in the hands, in the feet, arms, and the face of the child will also appear puffy. The other indicator of malnutrition, especially some, is blinding eye signs, things that you can see. And this one is often caused due to vitamin A deficiencies. If you look at the child's eye, you're able to see biotid spots, which are superficial foamy white spots on the conjunctiva, which is the white part of the eye. This is often associated with vitamin A deficiency. Corneal clouding is seen as an opaque appearance of the cornea. That is the transparent layer that covers the pupil and iris. You see it will appear a little bit cloudy. And this is a sign of severe deficiency of vitamin A. You can also see corneal ulceration in a break in the surface, or corneal laceration, which is a break in the surface of the cornea. It is a sign of severe vitamin A deficiency. If not treated, it's likely to cause blindness, and it requires urgent medical treatment to deal with it. So emergency signs, if a child presents in the hospital, let's say you are in an ER situation, emergency room, what is the first thing that you see? First, you have to check whether the airway of the baby is okay, if they have breathing problems. If not, you treat immediately. And then you check if the baby is in shock or the baby is dehydrated. And you check for dehydration, whether it's severe, whether it's mild. And if necessary, you resuscitate. If the baby is severely dehydrated, you do fluid resuscitation. If the baby is in trauma, you first give the first aid things that are needed to stop the external bleeding. And then you quickly determine if the baby is unconscious or convulsing. And then you give IV glucose to treat hypoglycemia, and convulsion, you give anticonvulsants to treat them. We can also carry out an emergency investigations. We check the blood glucose, we do the blood count, the blood smear, look at the HB. After doing all this, you proceed to assessing and diagnosing and treating the underlying problem. If no emergency sign is found, you check for other priority signs for malnutrition. So the emergency signs are anorexia. You give a child, make the child have an appetite test. Give them some plant peanut, for instance. See if they'll eat. See the child, if the child is drinking. If it is a child who's breastfeeding, are they breastfeeding adequately? So you assess all this to see signs and symptoms of anorexia. If the child fails the appetite test, this child is client for admission in the hospital. And then, as we've talked about the eye signs, we look at that. You look at issues with convulsion, you look at dehydration, you take the child's temperature, you check their glucose, if they have intractable vomiting, if they're lethargic, if they're in respiratory distress, if they have severe anemia. You look at their pallor to determine if this child is a candidate to be admitted in the hospital. So the other medical conditions that present with severe acute malnutrition are like candidiasis, congestive heart failure, and dehydration. You look at dysentery, helminthes, hepatitis, HIV, malaria, measles, meningitis, micronutrient deficiencies, persistent diarrhea, physical disabilities, skin infections, tuberculosis, and UTI. I skipped repeating syndrome because you're going to look at it as we continue. Okay, we have a child we've assessed for emergency situations. Now, what are we going to do next? If the child is a position for us to take anthropometric measures, we're going to take them. What are the anthropometric indicators? They are commonly used to objectively and promptly classify the nutritional conditions of children, and therefore they are used as a key criteria for admission. We measure the child's weight as soon as they're admitted, as soon as possible, if her condition allows. And then consecutively, you're going to check the weight of the baby at least once a day, if possible, around the same time you took the weight of the day. So weighing ideally should be 1 hour before giving any food to the child. And the anthropometric measures we're going to look at include medium upper arm circumference, or MWAC, and weight for height, Z-scores, which are going to help us categorize in which level this child is. So for the MWAC cutoff, we have for different ages, We have classification in terms of severe wasting, moderate wasting, or no wasting. So for a child between the age of 6 to 59 months, a mark of less than 11.5 means that there's severe wasting. So this child should capture our attention in this situation. And if it's a child between the age of 5 to 9 years, a mark of less than 13.0 centimeters. If it is a child who's between the age of 10 and 15 years, we're going to look at the mark should be around, if it's less than 16 centimeters, this child is of concern to us. Okay. So in terms of the way to hide this cause, this is an indicator for defining wasting. It is expressed in terms of the z-scores from the media of a standard population. It is used as a comparison measurements to the average median in the community. Let's say the child of the same age. Does this child compare to children of the same age? So that is how the z-scores guide us. So if a child falls under the category of less than -3 z-score, we say this child is severely wasted, and this is going to be a child of concern to us in terms of being admitted for treatment. So what is the admission criteria for the children between the age of 6 to 59 months for treatment in inpatient care? First of all, you look at a child who's presenting with bilateral PT edema, stage 3, or any grade of bilateral pitting edema but has a mark of less than 11.5. You can find that a child who has generalized edema, if you take the mark at that point, you're not going to get the correct value in terms of mark. So you have to do a good physical examination so that you really get to identify this. So, or you look at a child with some, that is severe acute malnutrition with any of the other medical complications like anorexia. They have poor appetite, they have intractable vomiting, they're convulsing, they're lethargic, they have hypoglycemia, their fevers are high, or they have very low fevers, or they're dehydrated, or they have severe persistent diarrhea, or they have severe anemia. And then for outpatient, that is a child with bilateral pitting edema, the first stage or the second, and then a mark, severe wasting, yes, with a mark of 11.5 centimeters. And if the child passes an appetite test, doesn't have any other medical complication, is clinically alert, you're going to treat this child as an outpatient. So reasons behind this criteria for identifying children in need of admission is that a child who has a mark of 11.5 is severely wasted. And if there is edema in both feet, the child has severe malnutrition, even though retained fluid may add to the weight of the child. So in this case, weight for height will not work in helping to identify if this child is severely malnourished. Any child with severe malnutrition and has medical complication is just a candidate to be admitted in the hospital to get all the necessary treatment. And children with severe edema and they have marasmus and kwashiorkor at the same time, we have to manage them inpatient. And a child who doesn't have a good appetite, obviously you can't send that child home. You have to treat them first so that they can get well. So I'm going to look at reductive adaptation. What is reductive adaptation? We find that when a child is severely malnourished, the child maybe has not been getting enough food. The body has not been receiving enough nutrients. So you find that the body adapts to the situation of not having enough nutrients. So you find that we have to give time for the baby system to start working properly once again. There is rapid changes. If you give too much water, it's going to cause problem. If you're going to give too much calories, it will give problems. So you have to be very cautious in how we are handling this child to prevent reductive adaptation. So malnutrition has different issues. Malnutrition has different issues to different body systems. So, like in the gastrointestinal system, the intestinal motility is reduced, so food does not travel quickly, and this can also cause diarrhea, which sometimes is hard to manage because of this issue. We have issues with the gastrourinary system. That is, the glomerular filtration is reduced. Capacity of the kidney to excrete excess acid or water is generally reduced. And they say all these consequences are the things that are going to lead us on how to manage this child. In terms of the liver, the synthesis of all proteins is reduced. There's abnormal metabolites of amino acids are produced. Capacity of the liver to take up metabolites and excrete toxin is extremely reduced. So that is why we need to be very cautious on how we are going to handle these children in terms of managing them. We find also that their immune system is compromised, and so we have to, like, the lymph glands, tonsillitis, and the thymus are atrophied. You find that cell-mediated T cells immunity is severely affected. So we have to make sure that we how we manage this baby. We have to be very cautious so that we give the body time to try to adjust and be able to work properly. So, what are the 10 steps of managing severe acute malnutrition? So, once we've identified this child, and we've admitted this child in the hospital, what are we going to do now? Okay, the first thing we're going to do is treat and prevent hypoglycemia. And this is done is done by giving glucose to prevent hypoglycemia. You do give glucose, and you feed 2 to 3 hours. First of all, you start with give glucose to treat hypoglycemia. Consequently, we are going to give this child F75 for in every 2 to 3 hours. We're going to give this child F75 for every 2 to 3 hours, and we are going to give it at a rate of 130 kilocalories per kg per day. So you calculate if the child's weight, let's say for instance, is 5 kilograms, you're going to calculate the 5 kilograms times the 130 kilocalories. And out of this, you're going to divide whatever you get in terms of the kilocalories by the number of feeds. Let's say you're going to give it in 8 feeds, which is ideal. You're going to divide the total by 8 feeds. So that is going to give you the quantity of the feeds you're going to give this child every 3 hours. So as you're feeding, you're going to also check for warning signs. Is the baby still being hypothermic? Is the child feeling cold? Is the child lethargic? And you're going to treat all this according to how they come. And then once we treat hypothermia, our goal is to keep the baby warm in any situation. You cover the baby, you keep the room warm, and the beddings and clothes should be dry, and you avoid a lot of exposure during examinations and during bathing. And we are also going to make sure that we take temperatures so often so as to monitor how the temperatures are going. If you're using heaters, for instance, you're going to take the temperature every 30 minutes to see how this baby is faring on. In situation, if the baby is so small, we can also do, and maybe the environment does not allow for keeping the baby warm, you can do the kangaroo method of keeping the baby warm. That is, the baby and the mother or the caregiver are skin to skin, and then the mother covers themselves so as to keep the baby warm. And then the third thing we're going to do, we're going to treat dehydration. And this we have to be very cautious. We are not going to give IV fluids except when the baby is in shock. And we're going to see is this baby having diarrhea? If this baby is having diarrhea, we're not going to use ORS to treat this diarrhea because of the osmolarity of ORS and what we have seen before. We are going to give instead a Resomol at a rate of 50 ml per each watery stool. That is for children who are less than 2 years of age, or 100 to 200 ml if the child is 2 years or 2 years older. And obviously, the warning signs of dehydration are the sunken eyes, slow pinch, skin pinch, absent tears, dry mouth, and a baby who seems to be very thirsty. And then we are going to, Resomol you're going to give at 5 ml per kg every 30 minutes for 2 hours initially. You orally or using nasogastric tube. If the baby is not able to take anything orally, you're going to use nasogastric tube. Then we give 5 to 10 meals per kg in alternate hours for up to 10 hours. So we're going to plan in such a way that it's day one, we've admitted this baby in the hospital. The baby came dehydrated, and we've identified this baby is severely malnourished. So we're going to make a feeding regime in terms of we're going to have Resomol and F75. Why do we start with F75? Because it's low in calories, and we want to avoid a situation whereby this baby goes into refeeding syndrome. And as we've seen, the systems tend to shut down when there's not enough nutrients, and we're just trying to resuscitate the system to work well again. So we are going to go slow in what we are giving in terms of be it fluids, be it the feeds. You're going to go slow to give the body time to recover from the state of shock that it is in, and also to help the baby recover quickly. So, and we have to be very cautious when rehydrating so as to prevent over rehydration. And how can we monitor over rehydration? We're going to see that the baby is likely to have increasing pulse and respiratory rate is often increased. We are also going to see the baby having edema that is increasing. Puffiness in the face is increasing, something which was not there before. So we have to be very keen and monitor. And we have to stop if the pulse, we have to stop rehydrating if the pulse increases by 25 beats per minute and the respiratory rate by 5 breaths per minute. And then the fourth thing, once we have managed dehydration, we're going to treat electrolyte imbalance. So we are going to use Resomol and F75 formulas, which are still going to give us electrolytes. And in this case, we are avoiding sodium, but we're doing more of potassium and magnesium. Why are we reducing sodium? If sodium is in excess, it's going to worsen the fluid retention in the body. So even if you're going to use kitchen feeds, for instance, maybe you don't have all this the F75, F100, you don't add salt to that food so as to not to increase the sodium that you're going to give this baby. So our target is to give extra potassium at 4 millimoles per kg body weight and magnesium at 0.6 millimole per kg body weight. And then after treating electrolyte imbalance, we're going to treat infections. Whenever a child is admitted with severe malnutrition, we have to assume that this child has infection. As we have seen, the effect of some in the body, it weakens the immune system. And you'll find that this child might not really show like they have an infection or anything because of the way the body is working. So we have to treat the infection immediately by giving broad spectrum antibiotics depending on the weight of the child. You can use, for instance, clotrimazole 5 ml pediatric suspension twice a day for 5 days. If the child is severely ill, you can give IV ampicillin and gentamicin ampicillin at 50 milligrams per kg 6 hourly for 2 days, or gentamicin at 7.5 ml IM once daily for 7 days. We can give metronidazole at 7.5 ml per kg per day, 8 hourly, for children with chronic diarrhea. And if the child fails to improve after 48 hours, we can add clomipirnacol at 25 milligrams per kg per day, 8 hourly, either IV or IM. Once we've managed to treat all this, we are going to treat micronutrient deficiencies, where we're going to give vitamin A. For children under 6 months of age, we're going to give 50,000 international units. And if the child is between 6 to 12 years, we're going to give 100,000 international units. As we had said before, vitamin A is of concern when a child has severe malnutrition, because it affects the baby's sight. And you're going to give folic acid, you're going to give multivitamin syrup, and you're going to give zinc. Iron is, we withhold iron for some time until the child comes out of danger. When managing this, we have two major phases. The stabilization phase and then the catch-up growth. So we hold iron until we are past the stabilization phase. And then we have to, after managing the macronutrient deficiencies, we are going to go to cautious feeding. Cautious feeding, that is where we give the F75, of which we start. All these steps, they happen concurrently. They happen concurrently, is only that there are some steps that we are going to do after just seeing some signs. Like, for instance, giving iron, we can't give it from day one. Or giving macronutrients, some we can't do from day one. So we are going to do them stepwise. Cautious feeding, like giving F75, we're going to start it from day one, so that we help the baby's baby's system to stabilize. And giving these feeds, you're going to give like 8 to 12 feeds in 24 hours. If the child has gross edema, we're going to reduce the volume. Instead of giving at 130 kilocalories meals per kg per day, we're going to give it at 100 ml per kg per day. And if the child has poor appetite, we coax the child at least to eat. And if it's not possible, we're going to give we're going to insert a nasogastric tube to feed this baby. And we have to be very cautious also when using the nasogastric tube, because we are likely to overfeed this child, because we just bypassing the digestive system, the mouth, and straight to the stomach. So we are supposed to be very cautious. And then once the baby's appetite is stable, that is when we transit to giving F100 as soon as possible. And then from F100, that is when we are trying to target catch-up growth, which is the 8th step, where we want to see this baby gaining weight. And all this, when you're going through all these stages, we have to make sure we're monitoring also the weight of the baby every day. So when you change to F100, you observe, okay, you replace F75 for F100. If you had written a feeding regime, you replace it. And then the baby takes F100, you increase the feed by 10 ml until some feeds remain uneaten. So you go increasing the feeds gradually. And then you also start introducing modified family meals, which are high in protein and high in energy. We can also use ready-to-use therapeutic feeds as an alternative for the F100. And then the 9th step is always to give a loving care, play, and stimulation. You try to stimulate this child to play and make the child feel loved, so that they may heal well. And then once all this is done, you're going to prepare for follow-up and discharge. You have to get information from the family background and their socioeconomic status. You instruct the mother and give it direct on how to prepare the meals, the foods, and how often to feed the child. And yesterday we had a talk about feeding fussiness and how to go about it. You can give the same tips to the parents as you're preparing them for discharge. You give them in situation maybe the baby is fussy, you try to make the feeding interesting, or you make the baby eat with the rest of the family and encourage the baby to eat as much as possible so as to enable us to make this catch-up growth. So you also link the baby to a clinic where they're going to be followed up on. So, what is the implication of reductive adaptation for some? You presume and treat infections. Nearly all, like I've said, nearly all children with some have bacterial infection. So you have to initiate treatment. You do not give iron, as I've mentioned, because of the reductive adaptation. A child with some makes less HB than usual. Iron that is not used for making HB is put in storage in the body. So the extra iron stored in the body, even though the child may appear anemic, giving iron early in treatment will not cure anemia since the child already has excess supply of iron in the body. Giving iron may also lead to free ions in the body and cause problems in three ways. First of all, free iron is highly reactive and promotes the formation of free radicals, which may engage in uncontrolled chemical reaction and damaging effects. The second thing, free iron promotes bacterial growth and can make infections worse. And then the body tries to protect itself from free iron by converting it to ferritin. This conversion requires energy and amino acids. So it's going to make our caloric needs increase even further. And then we have to provide more potassium, as I had mentioned, but we restrict sodium because sodium this affects the sodium potassium pump, which runs or slows or sodium potassium pump, and then it makes it slow. As a result, sodium in the cells rises and can increase edema. And this is something that is of concern because if you're not very keen on how we are managing patients with SAM, we are likely to lose them because of the refeeding syndrome. That is, you're giving too much food, you're giving too much calories that the body can't really manage, and you can worsen the situation. So what are the signs? What do we observe when you're talking of refeeding syndrome? We are observing signs like acute weakness, floppiness, lethargy, delirium, neurological symptoms, acidosis, muscle necrosis, liver and pancreatic failure, and cardiac failure or sudden and unexpected death. The syndrome is caused by rapidly consuming key nutrients. If the diet is unbalanced and the body shifts to glycolysis and anabolism when food is given. Frequently, there is large reduction in plasma phosphorus, potassium, and magnesium, and associated sodium and fluid retention. Thiamine deficiency is induced because glycolysis increases. So you find the baby needs more thiamine to carry out the process. And there's a risk of refeeding diarrhea or refeeding edema. So we have to feed this child very cautiously. And then we've talked about dehydration, and it's one of the effects of reductive adaptive state. That is, the body just either lets water to go, and when you give so much water, the body retains it once, which is not good. Okay, this slide shows the phases that are involved. I've gone through all the phases. So this is how we are going to go through them. The number of days that the baby is in the phases. So we have the stabilization phase. The baby comes in the hospital, they're sick, we have to stabilize them. Once they are stabilized, we're going to rehabilitate them. So, like treating hypoglycemia, treating hypothermia, treating dehydration, we do that in the first 2 days. And then Electrolytes will be given throughout the phase. It's only that things like iron, we're not going to give them from day one. We're going to give them from around once we know the infection is controlled, and then when we reach the extent that you're giving F100 or RUTF, which has more or less the same nutrients as F100. It's RUTF has iron in it, and we can also give macronutrients. We can give micronutrients also. And then infection prevention starts from day one, depending with the treatment regimen that you're using. If it's a 3-day regimen or it's a 7-day regimen, it also depends. And then we do cautious feeding from the first day to the 7th day. That is when we give F75. Once the baby has stabilized, that is when you transit to F100. So F100 you give when you want the baby to achieve catch-up growth. And then you have to do sensory stimulation from the time the child is admitted. You interact with the child. If the child can talk, you talk to them. If they play, you can give toys or things that will help them to stimulate their sensory nerves. And then preparing for follow-up all goes up to the rehabilitation phase. So the goals in the management phase, that is the stabilization phase and the stabilization and the rehabilitation phase. The goals is to reduce the diet to 50% of the recommended intake until all signs and symptoms disappear, and then gradually increase the amounts given. Check to make sure there is sufficient potassium and magnesium in the diet. If the diet is not based on cow's milk, you add additional phosphorus to prevent refeeding syndrome. For patients in the recovery phase, the child should be returned to the stabilization phase if there is deterioration during the transition to rehabilitation phase of treatment. The 10 steps, we've gone through them, all of them, and that was it for my presentation. Thank you. Anybody who has any questions or anything that needs clarification?
Lynn,
Yes.
thank you for the presentation. It was a good one. I have a question on management of SAM. You've mentioned the 75 and the 100 and Rizomol. In instances when you don't have the 75 and Rizomol that is supposed to use, what other options do you have?
If you don't have F75, you can use locally available materials. There are formulas that you can use to make them.
Like,
We can use, for instance, we can use cow's milk. We have the ingredients that you'll need will be cow's milk or dried milk. You'll need electrolyte or mineral solutions. And then you use this to make the F75. The quantities that you need to mix all this. You'll use the same to mix F100, but the ratios are what matters because the ratios is what is going to determine if the F75 is for real going to have the 75 kilocalories or if the F100 is going to have the 100 kilocalories. There are specific ratios that you need to make these formulas.
okay, thank you. Well,
You're welcome.
you said the 75 is for stabilization.
Yes.
I've had, what if you only have a 100? Can you use it?
If you have F100, you dilute it.
I dilute it at what ratio?
I'm not so sure of the ratios, but I'll get back to you about it.
Okay, thank you.
Okay. Thank you, Penina, for your question. Anybody with another question?
Thank you so much, Erin, for that contribution about malnutrition. Indeed, your timing.
Sorry, come again?
Can you hear me?
Yes, I can.
I'm saying thank you so much for your timing is so smart. Since now the country is facing the acute, the chronic malnutrition.
Mm-hmm.
So I think your timing is so smart. And I hope the health workers can really help those counties which are really affected with malnutrition.
Mm-hmm.
And I know that many counties are facing stockouts of the commodities. Like Fenina is saying the issues of F75, peppermint, Lexomol. It is the early time now. Many counties employ or engage nutritionists in the practice so that
Mm-hmm.
they are able to use their knowledge which they are taught in school in using the locally available materials, like in cases of stock out of the lesson, which is the major you have talked about the issues of sodium and potassium. So if they give ORS, we may lose many kids. So lesson
Mm-hmm.
is the during these initial stages, and
Mm-hmm.
many counties lack the commodity. So
Mm-hmm.
I think you had the note on the preparation of locally available, which
Mm-hmm.
many people don't understand, but I hope they will use the locally available commodity at least to
Mm-hmm.
help our county, our country, Kenya,
Mm-hmm.
who's now facing a lot of issues with hunger. Thank you
Mm-hmm.
so much. The contribution was good.
Thank you. Like, if someone was taking notes, if you are to prepare, let's say F75, for instance, you need like if you're using full cream cow's milk, you're going to use like 300 mLs of the milk, and then you're going to use 100 grams of the sugar, 20 grams of oil, and 20 mLs of electrolyte or mineral solution. And then in all this, you're going to put it in 1,000 mils boiled cool water. And if you're going to make F100, you're going to use 880 mLs full cream cow's milk, 75 grams sugar, 20 grams oil, 20 ml electrolyte or mineral solution, and 1,000 mLs water. That is water that you've boiled and you've cooled. So you can use that is if you're using full cow's milk, or you can use dried milk, which is also available, or you can use dried skimmed milk. The only thing that changes is the ratios of what you're going to add. Like, for instance, if you're going to use full cream, you're going to use like 35 grams of the milk powder to make F75, or and 20 grams of oil and 20 mils of electrolyte or mineral solution, and you still add this to 1,000 mLs of water. So you're going to have the same formulas with the same number of calories that you're targeting, the same number of proteins that you're targeting for this child. Thank you for that. Anyone with another question?
Uh, to insist on that, many people confuse the inpatient management and the outpatient. Please comment on that because we may talk all about these ingredients and people start practicing it back at home. So it's good to when to use what.
Mm-hmm. Like I had said in the previous, I had talked about the criteria of including like criteria of admitting the child to be inpatient. And most of the time, you have to see a child who has severe edema, we can't treat them as outpatient. A child who fails an appetite test, we can't treat them as outpatient. A child who has a child who has doesn't failed appetite test, severe edema, a child who has infections, a child who's in shock, we can't treat them as outpatient, we treat them as inpatient. And for outpatient children, it's a child, when you see the child is alert. When you do the appetite test, the child can eat well and they finish whatever portion you're giving them at that specific moment. That is a child that you can discharge at home to be treated as outpatient. So we can't really risk, as in the line is so clear on who is to be admitted and who is to be treated as an outpatient. Because a parent staying with a sick child at home, not a good idea. Hope I've answered your question.
Thank you.
Okay. Any other person with a question? If there's none, thank you for your time and thank you for your audience. Back to you, Milan.